Hey, Dr. Michael Miyazaki here, and I am glad you're back with me. We're going to talk about endodontics today, and specifically about endodontic irrigation. Now, endo to me is really important. Again, I'm in a family practice, try to do a little bit of everything for our patients, and I think that's an important part. Last Friday, I had a patient that came in, had not slept for 2 days because of a toothache, could not tell which area hurt. So we did our testing, and it was still very inconclusive. It was like 3 teeth to 4 teeth down on the lower left hand side hurt. And I didn't want to do a root canal on a tooth unless I knew which tooth to actually treat. So in this case, we did our testing, and all the teeth in that quadrant were sensitive. Tapping, percussion, and then cold was kind of questionable. The teeth could actually, he could actually feel the cold, and it was transient pain. So I had to step it up. We used our CBCT, and with the CBCT, we could pinpoint which tooth it was. And we got in there, numbed it up, and opened the tooth up, and let it drain. And there was pus in that tooth because we had a necrotic pulp. So it was very difficult, one, to diagnose for sure, but two, being able to start the root canal. And this gentleman came in with his son, and I told the son, hey, we have to do a root canal because your father's tooth has basically died, and he's starting to get an infection, and that's why it hurts so much. And the son looked at me and said, you're going to do the root canal now? And it was Friday afternoon. And I said, yes, we can start doing the root canal now so that your father's out of pain. And the son said, wow, last time I went to the dentist, they had to refer me out to have the root canal done. And I said, no, this root canal we could do here. So it really impressed the son. And the son, before he left, said, I'm going to fill up your schedule with my family. And I said, cool, that's great. But what was really kind of nice is 2 days later, I saw the gentleman that we had worked on that Friday afternoon, and he was doing great. All the pain was gone. He was comfortable. And that's kind of the rewarding part of doing endo. But what we're going to focus on today is, if you don't know about endodontic irrigation, it could be hurting you, and literally it could be hurting your patients. So I want to just kind of go through some of that today. So as we know, as we do a root canal, we have the procedure, and what we're trying to do is we're trying to remove all the infected tissue. That could be necrotic pulp, it could be an unhealthy pulp from the tooth. But then we have to get all the byproducts. We have to get the bacteria out, and all the contamination that is in that canal space. And then we have to shape it so that we can get a sealer of some sort into that root canal space that will seal it up nice and tight. So we have special sealers, and we have our gutta percha. The gutta percha is mainly for the hydraulic force to push our sealer out laterally and apically, and allow us a way to get back into the tooth and retreat it if we should need to have to do that. So as we go through this, sorry, my little mouse is real sensitive today. But what we know is from the statistics is that the majority of root canals, about 72%, are done by general practitioners. So I have a lot of my colleagues who are GPs, and they say, well, I don't really want to do root canals because they're very difficult to do. And like anything, when we go back and look at how we did our composite restorations back in dental school, it was very difficult, but after doing 1,000 of them, they get a lot easier. Same thing with root canals. Now, we don't have to do the most difficult of root canals or work on the most difficult of patients. We can refer those out to the endodontist. But what we want to do is we want to make sure that if we do a root canal, that we have a good chance of having success. In order to understand how to have success, I think we have to understand why we can have failures. And we can have failures because the goal is to clean out the root canal system of vital and necrotic tissues, any kind of microorganisms, and get all that out. But it's very difficult because the root canal systems aren't just, let's say in a molar, if you don't have the MB2, it's not just two buccal canals and a palatal canal, but we could have those three canals and an MB2, and then we could have these lateral canals connecting everything together. So if we fail to remove that tissue and the bacteria from all those canal spaces, then we run the risk of that area not being able to heal. We could get another subsequent infection which would result in retreatment and possibly loss of the tooth. Sometimes the patients just kind of give up. Oh, I had a root canal already and that tooth still hurts. I don't want to go through that again, so let's just take the tooth out. And for us as dentists, what we want to do is we want to make sure that our patients are comfortable. And if they're not going to be comfortable, then we can lose sleep, if we're worrying about how our patients are doing. And then as practice owners, we lose that revenue, so that can lead to more loss of sleep. So it's really win-win if we can do the root canals and we can do them properly. Now, we know we have the main canals, and those are the ones that, we look at the diagrams. I've got 1 canal, 2 canals. What is most common? Now, that main canals, we get our main files down. So we have, let's say, that molar again where we don't have an MB2, and we've got our 2 buccal and we have our palatal. So we search for those orifices as we open up into the pulp chamber. We find those. We get our main files down those orifices, and we begin our instrumentation. Now, the main cause of treatment failure is just the bacterial persistence within that root canal system. And if we can disinfect that root canal system, our success rate would go up dramatically. And as I've told you before during these YouTube programs, is that many times in our practice, if we have a patient that presents with an endodontic problem, we'll try to do the root canal and possibly even put the crown on during that same appointment, which means we have to be really confident that that tooth is going to heal. So I want to stack everything in my favor as far as the odds. Now, what challenges our success? Is this the anatomy? What is the canal system like? How many canals are there? How are the lateral canals? How many? How much of that space can we clean and how much of that space can we not clean? And then time. Today with our instrumentation, our rotary or reciprocating file systems, we can get done much faster, which is good for us and the patient, but the exposure time of that tissue and those lateral canals in the canal system, the time that is exposed to our different irrigants is much decreased, and so things go much faster. So irrigants are when we put something into a body cavity, a root canal system, that will work within that system either to clean it or to medicate it. A disinfectant is an agent that destroys or inhibits the activity of microorganisms, and in this case within that canal system, that causes the discomfort or disease. And sometimes we can even aspirate or we can remove fluid using our little irrigation needles, which is very convenient for us to do. But what does an irrigant do? An irrigant, when we first start our root canal and we get our files in there, it may act as a lubricant. It's something that's moisture within that canal system that allows our file to go up and down and interact with the walls of the canal without creating as much stress, which might be good for preventing the formation of microfractures. As the tissue and the walls of the canal system are kind of scraped with our files, the fluid in our irrigants helps us suspend those particles so that we don't create a real thick mud and start packing that down into the apex. The irrigants could start to dissolve, like that pulpal tissue. Our sodium hypochlorite will begin to dissolve that tissue, so it just kind of begins to melt away, and our inorganic portions of the tooth. And if we have bacteria in there, many of our irrigants are going to disinfect the canal system as we irrigate. And something like EDTA will help to remove the smear layer so that when we place our sealer actually bonds better to the internal walls of our root canal system. So the irrigants are going to do a lot of our cleaning, and I think that's the important part. So right now I'm actually in the process of, let me see if I can get this to work for you. I'm in the process of remodeling the house. So I get in there, I'm tearing walls down, I'm taking insulation out, and I'm just getting really dirty, and I'm creating a lot of debris. And I think of this as when we do a lot of our dental work, we're taking a structure like a tooth and we're removing all the bad parts of it to rebuild it to be stronger. When we do a root canal, we're doing much of that. We're taking out that bacteria, we're cleaning out the walls of the tooth, and we're cleaning it before we can make it stronger or healthier. So I think of it as remodeling. When I take my files down into that canal system, what I'm going to do is I'm going to create a lot of debris. So here's the file, and you can see it's going into an acrylic block so we can watch it work, and you can see all the debris begin to be formed in that area, and then we have to flush it out. Now what you saw was as that file goes into the acrylic and begins to rub the walls of the acrylic and create the chips of acrylic within that area, it gets very cloudy and we have to rinse that out. So the file is doing the same thing within a root canal system. We need to have an irrigant in there so as those acrylic particles are being formed by our file, you can see they're suspended. They're not being packed down into the apex, but they're being suspended within the fluid. So what we have to do is in endodontics is we have to find the main canals. Those main canals are going to allow us to get our irrigants down into the root canal system. And then the irrigants are going to work to dissolve the tissue in all those lateral spaces and begin to disinfect the canals and the tubules. And that's what's really important. It's before, I think, when I was learning how to do root canals almost 40 years ago, I was thinking the mechanical work of the files was like a pipe cleaner cleaning out your pipe. It was clean the walls of the canals out. But what we've learned is it has to be much more. The mechanical part of the cleaning is only one part, because the research by Dr. Peters here shows that only approximately 35% or 65% of the canals are actually cleaned, and 35% of the canals are really untouched. So the red areas are the areas that haven't been touched after files have been taken into the tooth, and the areas that have been cleaned are represented in blue. So what we can see is we have a lot of residual tissue or bacteria potentially left in that root canal system. And what the research shows is we're moving from canal shaping as being kind of a way of cleaning the tooth to chemo-mechanical canal cleaning. So we have to have the mechanical part and the chemical part working together in order to get the canal system clean. Now, one of the primary irrigants that we start with is usually sodium hypochlorite, but clinicians use a myriad of different materials like EDTA, chlorhexidine, saline, MTAD, and citric acid, and some I know even use anesthetic. But the majority is using sodium hypochlorite. So let's focus on sodium hypochlorite. Sodium hypochlorite is a really common irrigating solution. It is the one that I learned to use 40 years ago. Why? It's antibacterial, and it dissolves the tissue. So if we've got pulp tissue that's in the system, we want something that gets into the root canal system to actually dissolve that necrotic tissue away, or vital pulp tissue, and then allow us to remove that. And Clorox has been around for a long time. You know, I was at the store the other day and I went and took this picture of the Clorox bottle. So it's really good for tissue dissolution and disinfection. The problem with Clorox, the Clorox from the bottle that you see right here, is it's not intended for clinical use. It wasn't designed for root canals. So what I would encourage you to do is use sodium hypochlorite, but use a pharmacy grade or pharmacy controlled type of sodium hypochlorite. It'll have an expiration date so that you are assured that when you're using it, you know what the concentration is, 3 to 6%, and that it's actually going to work when you use it as your irrigating solution. Then as we use our files in the canal system and we create that dentin mud, what we have to do is we have to remove that smear layer so that our sodium hypochlorite can get into those little tubules. Now, if I start to file that out and I create dentin mud, the dentin mud, just like when you prepare a tooth, we have to take that prepared tooth, and before we bond something to that tooth, we have to remove the smear layer from the dental tubules, and we use our phosphoric acid etchants. But in this case, EDTA is going to do the same thing. It's going to chelate and remove the smear layer, open up the dental tubules, and then we can go back in with the sodium hypochlorite, which will then dissolve and kill the bacteria in those tubule spaces that we may not have been reaching before because the tubules were plugged up with our dental mud. So we've got our sodium hypochlorite that's going to dissolve our pulpal tissue, that's going to disinfect the system, but then we're going to have create all this mud, all this debris within that root canal system. So then we're going to irrigate with our EDTA, because the EDTA is going to remove that smear layer, open up the tubules again, and that is very advantageous for us at this point. So remember, we're doing this chemo-mechanical cleaning of our root canal system. Now, the third irrigant that a lot of clinicians use is chlorhexidine. Why chlorhexidine? Well, has a broad spectrum of action as far as being antimicrobial. Works on gram-positive, gram-negative bacteria, and even anaerobes like yeast and fungi. One of the primary benefits is it has what we call substantivity, which means after we irrigate the canal with our chlorhexidine, it will keep working. It's not going to just be removed immediately. It's going to keep working. So a lot of times it's our last irrigant because it's antimicrobial. And some think that it can increase the durability of our hybrid layer by inhibiting the MMPs. And I think that can be very important when we're using our sealers. But one of the things about it is some people have thought, well, maybe we could use it as our primary irrigant and replace sodium hypochlorite, because sodium hypochlorite can be cytotoxic. So chlorhexidine is broad spectrum as far as its antimicrobial action, has that substantivity and low toxicity. However, it doesn't dissolve the tissue like sodium hypochlorite. So it's one of the reasons why we recommend using sodium hypochlorite, EDTA to remove the smear layer, and then sodium hypochlorite to get back into the tubule spaces after the smear layer has been removed. Then rinse out the canal, and then use chlorhexidine to prolong the action of killing that bacteria. So sodium hypochlorite dissolves the organic debris. EDTA kind of chelates all that debris to remove the smear layer to make it easier for our resin sealer to bond to the canal walls. And the chlorhexidine has the antibacterial action with the substantivity. Now, one of the things we have to remember is don't put the chlorhexidine in right after you've used the sodium hypochlorite. What you want to do is you want to use the sodium hypochlorite and then rinse out the canal with saline, or you could use something like EDTA, but rinse out the sodium hypochlorite and then use your chlorhexidine. Because if you mix the chlorhexidine with the sodium hypochlorite, you will form a precipitate, and you don't want to have that. So with these three common irrigants, I'm going to leave you with a thought. If you have sodium hypochlorite, you have ethylene diamine tetraacetic acid, your EDTA, and you've got chlorhexidine, in your irrigation protocol, what would be the sequence you would use and why? And we're going to talk more about the type of sodium hypochlorite you want to use, and the type of EDTA you want to use, and the type of chlorhexidine you want to use, because they are not all created equal. And remember, I said one of the things that causes endodontic failures is the anatomy of the system, which we know can be very difficult, but lack of time. We get done with these procedures much quicker now, and if we don't give our irrigants enough time to actually have their effect, we could fail. So what we're going to talk about is we're going to talk about kind of these new advanced irrigants that will help us succeed. So if you were to use all three of these endodontic irrigants in your endodontic irrigation protocol, what sequence would you use and why? Well, maybe sodium hypochlorite, because that's going to help lubricate the canal. It's going to help us get some tissue dissolution. It's going to dissolve that pulpal tissue or necrotic tissue. It's going to disinfect the system. All great things. And it's going to hold that debris in suspension. Then we can use EDTA, because the EDTA is going to help to remove that smear layer or the dental mud from the canal walls. It's going to open up all those lateral spaces. And then we can get back in there with our sodium hypochlorite, and we can now get the sodium hypochlorite into those lateral spaces. And we'll talk about it. Well, how do we do that? Well, we can activate that solution now and get it into those lateral spaces, which is going to be very, very important, again, to our long-term success. Then what do? Is we irrigate it out with water. And then the last step is we can use chlorhexidine, because it has a broad spectrum antimicrobial action with the substantivity. Now, if we mix all this together, I think we have a recipe for success. So think about it, and send your comments in if you feel you're using different irrigants and the reason why. I think it's a great way that we can discuss this and learn from each other. Again, I hope you like these weekly installments. I hope you subscribe so you know when the new ones come up. And I hope that you enjoy being this community of like-minded clinicians that really want to do our best for our patients and have a healthy and thriving practice so that we can enjoy our life and our patients can enjoy theirs. So anyway, I hope you like this short segment on endodontic irrigation. We've got a lot more we can go into depth with, and I'm so excited about this. And this week, I'm actually doing a program just like this, and it's going to be going to a third of the way around the world. Luckily, it's going to be by a webinar. And so this information is spreading, and know that you are at the forefront of endodontic irrigants. All right, take care. Thank you very much.